In this presentation, I will go through the most common and severe of the interstitial pneumonias, idiopathic pulmonary fibrosis or IPF. The definition of IPF is a chronic, progressive, irreversible fibrotic interstitial lung disease of unknown origin. The diagnosis requires exclusion of any other cause of pulmonary fibrosis and a typical UIP pattern on HRCT or a probable UIP pattern in the right clinical context, which I will get back to later. If this is not evident, it requires biopsies for histologic evaluation for a UIP pattern. There are no large studies on the epidemiology of IPF, and the estimates we have are therefore varying. The incidence of IPF is estimated to be between 7 and 16 per 100,000 inhabitants, and the prevalence between 14 and 43. Both the incidence and the prevalence increase with age. The disease is typically seen in males over 50 with a mean age of 67 years at diagnosis, and approximately 75% are smokers or ex-smokers. In Denmark, 300 to 400 patients are diagnosed with IPF each year. IPF has a poor prognosis with a median survival of 3 to 5 years from diagnosis if no treatment is given. The natural history of IPF is very unpredictable. Some patients experience a rapid decline while others progress much more slowly. Some patients experience a more mixed course with acute exacerbations and in between more stable periods. The typical symptoms of IPF are dyspnea, dry cough and fatigue, symptoms that patients with any LD experience. And typical findings are bibasilar crackles, and for some patients, clubbing is evident. As mentioned earlier, the IPF diagnosis requires exclusion of any other cause of pulmonary fibrosis and a typical UIP pattern on HRCT or a probable UIP pattern in the right clinical context. This means that if you have a probable UIP pattern in a typical patient, that is, a male more than 60 years of age, smoker or ex-smoker, with insidious onset of dry coughing and exertional dyspnea, basilar crackles and radiological evidence of fibrosis in the lower lobes. This can also be applicable in middle-aged adults, especially in patients with risk for familial pulmonary fibrosis. HRCT criteria for UIP pattern. The typical UIP pattern has subpleural and basal predominance, often with a heterogeneous distribution. There's reticulation and honeycombing with or without peripheral traction bronchiectasis. The probable UIP pattern also has subpleural and basal predominance, reticulation with traction bronchiectasis, but no honeycombing changes. For some patients, it may be necessary with invasive investigations with BAL and biopsies. This is all presented in this flowchart. As you can see to the left, after MDD, BAL and surgical lung biopsy or cryobiopsy, if this procedure is available, is recommended to reach a diagnosis. The histopathological criteria for a definite UIP pattern is patchy dense fibrosis with architectural distortion with a subpleural or paraseptal distribution, fibroblast foci, and absence of features suggesting an alternative diagnosis. Probable UIP pattern shares some of the features from the definite UIP pattern, but to an extent that precludes a definite UIP diagnosis, an absence of features suggesting an alternative diagnosis. This table can then be used when you combine the radiological and pathological findings to find out whether the patient has IPF or not. There are two types of antifibrotic treatment available for patients with IPF, pirfenidone and nintedanib. Both slow down progression but do not cure the disease. The ASCENT and the IMPULSIS trials are the phase 3 trials behind the treatment. Both were placebo-controlled, double-blinded studies where treatment was given for 1 year. The Ascend and the Impulses trials are the phase 3 trials behind the treatment. Both were placebo-controlled, double-blinded studies where treatment was given for 1 year. Both studies showed reduced rate of decline of FVC. In the Ascend trial, survival improved. The Impulses trials were not powered to show a difference in mortality between nintedanib and placebo, but did show a prolonged time to first acute exacerbation. Differences in study populations preclude direct comparisons of effect size, as seen on the previous slide. Side effects of both drugs are manageable and includes nausea, dyspepsia, vomiting, diarrhea, and fatigue. Symptom relief can include codeine or morphine, low-dose prednisolone, long-term oxygen treatment if indicated, and rehabilitation. Not many studies have been done on rehabilitation in IPF, but it is found to be safe with no adverse effects, and studies have showed improved 6-minute walk distance, quality of life, but no long-term effects on clinical variables or survival at 3 and 6 months. Proton pump inhibitor can be given if the patient has reflux. Transplantation is also an option for a small percentage of IPF patients. Studies show that median survival after lung transplantation is 4.7 years. When working with a chronic and severe disease like IPF, it's important to consider all of the patient's needs and manage them with a holistic approach. Apart from rehabilitation, long-term oxygen treatment, and symptom relief, it's also important to emphasize patient education, what to expect, how to react to side effects, and it's also important to include spouses or other family members. To prevent exacerbation, we recommend the patients getting vaccinated and treat infections with antibiotics. It's also important to treat comorbidities and to look for signs and treat depression if this is evident, and to discuss and support with end-of-life care. In this short presentation, I will go through the pathology in interstitial lung diseases. In this short presentation, I will go through the pathology in interstitial lung diseases. So the pathologist works with both the cytology of BAL and histology of lung biopsies that can be obtained by either transbronchial biopsies by forceps, transbronchial cryobiopsies, surgical lung biopsies, or even explanted lungs. When examining the BAL, the differential cell count is an important tool in the diagnostic workup for ILDs, as identification or exclusion of an inflammatory cellular pattern may support a specific ILD diagnosis or help narrowing the differential diagnosis. Also, infectious agents like fungi and pneumocystis can be detected. The BAL should of course also be sent to microbiology for bacterial and fungal cultures and/or viral PCR if suspected. The pathologists also look for asbestos bodies, crystalline particles that can be seen in silicosis, alveolar hemorrhage and the finding of hemosiderin-laden macrophages, or pus-positive amorphous debris and a cloudy or milky BAL fluid that can be seen in alveolar proteinosis. Also, malignant cells can be detected. When examining the BAL, the differential cell count is an important tool in the diagnostic workup for ILDs, as identification or exclusion of an inflammatory cellular pattern may support a specific ILD diagnosis or help narrowing the differential diagnosis. Also, infectious agents like fungi and pneumocystis carinii can be detected. The BAL should of course also be sent to microbiology for bacterial and fungal cultures and/or viral PCR if suspected. The pathologists also look for asbestos bodies, crystalline particles that can be seen in silicosis, alveolar hemorrhage and the finding of hemosiderin-laden macrophages, or pus-positive amorphous debris and a cloudy or milky BAL fluid that can be seen in alveolar proteinosis. Also, malignant cells can be detected. When examining the BAL, the differential cell count is an important tool in the diagnostic workup for ILDs, as identification or exclusion of an inflammatory cellular pattern may support a specific ILD diagnosis or help narrowing the differential diagnosis. Also, infectious agents like fungi, Pneumocystis carinii, or mycobacteria can be detected. The BAL should of course also be sent to microbiology for bacterial and fungal cultures and/or viral PCR if suspected. The pathologists also look for asbestos bodies, crystalline particles that can be seen in silicosis, alveolar hemorrhage, and the finding of hemosiderin-laden macrophages, or positive amorphous debris and a cloudy or milky BAL fluid that can be seen in alveolar proteinosis. Also, malignant cells can be detected. The normal cellular differential count in non-smoking adults are alveolar macrophages of more than 85%, lymphocytes of 10 to 15% with a CD4-CD8 ratio of 0.9 to 2.5, neutrophils of 3 or less than 3%, eosinophils of 1 or less than 1%, and squamous epithelial or ciliated columnar epithelial cells of 5 or less than 5%. Disorders associated with lymphocytosis are, for example, sarcoidosis, NSIP, hypersensitivity pneumonitis, drug-induced pneumonitis, connective tissue disease ILD, while eosinophilia can be seen in eosinophil pneumonitis, drug-induced pneumonitis, or different infections. Neutrophilia can be seen in connective tissue disease, ILD, IPF, and also in different infections. When examining the tissue, there are many different elements to consider. Is the architecture normal or altered? Is it fibrotic? Is the distribution diffuse or patchy? Is it bronchocentric, and is there honeycombing? The age of the fibrosis is determined by the finding of temporal heterogeneity or uniform fibrosis. The age of the fibrosis is determined by the finding of temporal heterogeneity or uniform fibrosis. Then there is the interstitial content. Does it contain mononuclear cells or granulomas? And does the alveoli have any fillings of macrophages, immature fibroblasts, or non-cellular material? Is there any signs of vasculitis or wall thickening? And is there inflammation or fibrosis in the pleura? And is there any finding of inflammation or fibrosis in the pleura? It is also important where in the lungs the changes are most pronounced. Is it in the interstitium with a cellular or fibrotic predominance? Is it airspace predominant, or is it a vascular disease? As with HRCT, in histology, it's all about pattern recognition. A suggestion for a diagnostic report for histology evaluation has been proposed by Ravaglia for cryobiopsies, but it is relevant for the different types of biopsies. The report should contain the site for the biopsies, the size of the biopsies, if the sampling is central or peripheral, which histologic pattern can be seen, and the level of confidence. A suggestion for a diagnostic report for histology evaluation has been proposed by Ravaglia for cryobiopsies, but it is relevant for the different types of biopsies. The report should contain the site for each biopsy, the size, if the sampling is central or peripheral, which histologic pattern can be seen, and the level of confidence. This information is valuable for getting to a confident diagnosis. In this presentation, I will go through the different radiologic patterns in interstitial lung diseases and the typical patterns seen in some of the most common diseases. I will not go through the other common findings like pulmonary edema, infections, or cancer. When going through HRCT scans, the location of the changes are essential. Upper lobe distribution can be seen in, for example, sarcoidosis, silicosis, Langerhans cell histiocytosis, chronic eosinophil pneumonia, and respiratory bronchiolitis. Lower lobe distribution can be seen in, for example, UIP pattern, NSIP, asbestosis, and organizing pneumonia, while diffuse distribution can be seen in, for example, sarcoidosis and lymphangioliomyomatosis. Peripheral distribution can be seen in, for example, UIP, NSIP, chronic eosinophil pneumonia, and organizing pneumonia, while central distribution can be seen in, for example, sarcoidosis or pulmonal alveolar proteinosis. Centrilobular distribution of nodules can be seen in, for example, hypersensitivity pneumonitis and respiratory bronchiolitis. Perilymphatic distribution can be seen in sarcoidosis and lymphangitis carcinomatosis, while random distribution can be seen in miliary tuberculosis or metastasis. Typical radiological patterns seen in ILDs are reticulation, which is thickening of the interlobular septa that can be caused by fluid, infiltration of cells, or by fibrosis. Ground glass opacities are increased lung attenuation without obscuration of the underlying vessels. It's called consolidations if the increase in lung opacity obscures the underlying vessels. It's caused by the replacement of air in the alveoli by fluid, cells, or fibrosis. Other typical patterns are nodules and cysts, which I will get back to later. Honeycombing is clustered cystic air spaces with irregularly thickened walls, typically 3 to 10 mm, caused by fibrotic tissue, predominantly found in the peripheral and subpleurally. Additional findings can be bronchiectasis or traction bronchiectasis, pleural fluid, lymphadenopathy, and emphysema. Radiological usual interstitial pneumonia, or UIP, is a combination of different features seen in patients with IPF. It can also be seen in other ILDs, like, for example, connective tissue disease ILD and fibrotic hypersensitivity pneumonitis. A new guideline on the diagnosis of IPF was published in 2011 and updated in 2018. In this guideline, they made 4 categories for UIP pattern, which I will go through. First, there's the typical UIP pattern with subpleural and basal predominance, with reticulation, traction bronchiectasis, and honeycombing. The second category is the probable UIP pattern, also with subpleural and basal predominance, with reticulation and traction bronchiectasis, but in this category there's no honeycombing. The third category, indeterminate for UIP, can also have subpleural and basal predominance, but with only subtle reticulation and mild ground glass opacities that might be suggestive of an early IPF. The last category is the alternative diagnosis, with patterns or distribution suggestive of another diagnosis. Now I will present some of the other typical findings in other interstitial lung diseases. The typical non-fibrotic hypersensitivity pneumonitis pattern shows small airways disease with ill-defined small centrilobular nodules. When very profuse, the centrilobular nodules may coalesce, creating areas of ground glass opacities. Then there might also be mosaic attenuation on inspiratory images and air trapping on expiratory images. The typical non-fibrotic hypersensitivity pneumonitis requires at least one of the earlier mentioned parenchymal changes and one of the changes of small or airways disease. The distribution is diffuse. The typical pattern seen in fibrotic hypersensitivity pneumonitis has coexistent lung fibrosis. The lung fibrosis most frequently manifests as irregular reticulation with lung distortion that can be seen in association with traction bronchiectasis in areas of ground glass opacities. Honeycombing can be present. The lung fibrosis is most severe in the mid and lower lung zones, or equally distributed in the 3 lung zones. Typical UIP pattern in the lower lobes may be evident in patients with scans compatible with hypersensitivity pneumonitis. Apart from signs of fibrosis, at least one feature is suggestive of small airways disease like centrilobular nodules and/or ground glass opacities, mosaic attenuation, air trapping or 3-density sign has to be present. The 3-density sign refers to the presence of 3 different lung densities, namely ground glass opacification, lobules of decreased attenuation and vascularity, and normal lung, and is highly specific for fibrotic hypersensitivity pneumonitis. The NSIP pattern is more diffusely distributed or with a basal predominance. In 30% there is subpleural sparing. The typical findings, in various degrees depending on if the disease is more cellular or fibrotic, are ground glass opacities, reticulation, traction bronchiectasis, and thickening of bronchiovascular bundle. Nodules are distributed in a centrilobular, a perilymphatic, or a random pattern. In diseases that enter the lung through the airways, like hypersensitive pneumonitis or respiratory bronchiolitis, the distribution is centrilobular. The pleural surface is spared when there is a centrilobular pattern. In patients with a perilymphatic distribution, nodules are seen in relation to pleural surfaces, interlobular septa, and the peribronchovascular interstitium. Diseases with this pattern can be sarcoidosis, silicosis, or lymphangitic spread of carcinoma. The random distribution is a result of the hematogenous spread and can be miliary tuberculosis, carcinomatosis, or hematogenous metastasis, or early stages of histiocytosis X. It can be seen in sarcoidosis, although a perilymphatic distribution is more common. The nodules are usually seen to involve the pleural surfaces and fissures, but lack the subpleural predominance often seen in patients with a perilymphatic distribution. Langerhans cell histiocytosis is one of the cystic lung diseases and are characterized by multiple diffuse nodules with central lucency varying in size and wall thickness, distributed evenly with a predilection for the mid and upper zones. Later on, the nodules become cysts with variable wall thickness. The cysts can confluence into bizarre shapes. Lymphangioliomyomatosis have thin-walled, diffuse, uniformly round cysts of variable sizes surrounded by normal lung parenchyma that can be seen throughout the lung. Lymphocytic interstitial pneumonia has variable-sized, thin-walled cysts with mid or lower lung predominance and often perivascular. There can be thickening of the bronchovascular bundles, centrilobular nodules, and ground glass opacities. In Birdhoff-Dubé, the patient has multiple thin-walled cysts, predominantly seen in peripheral lung zones, at lung bases and along the mediastinum. The cysts are often elongated and arranges in clusters. The last disease I will go through is organizing pneumonia. Typical findings are multiple and migrating patchy consolidations, small ill-defined peribronchial nodules, ground glass opacities or crazy paving, and reverse halo sign as highlighted with the white arrows.